After metformin, there is a wide number of agents that can be used as second line in type 2 diabetes. And the challenge is choosing which agent is right for which individual. And life has got a bit more complicated with the number of agents available. Guidelines, processes, NICE will help you to some degree, but there's still a choice to be made. And for me, I would go on factors, two major factors. One would be risk of hypoglycemia. If you deem your patient is at risk of hypoglycemia, and there are a number of risk factors for hypoglycemia, then you would avoid a sulfonylurea, such as glycoside or glipizide. That's something that we're more and more aware of, the risks of hypoglycemia with sulfonylureas. So which agent would we use? So the choices we would have are a DPP-4 inhibitor, which has modest effect and is weight neutral. Alternatively, we have a GLP-1 receptor agonist injections, which have more efficacy in glucose reduction, but has the advantage of weight loss. And most recently, a few weeks ago, has shown that a certain GLP-1 agonist is associated with lower cardiovascular mortality. Thirdly, if a patient is not amenable to injectable therapy, has an excessive BMI, there's an oral therapy available, which is an SGLT2 inhibitor, which stands for sodium glucose transporter inhibitor, which works on the kidney to promote glucose disposal via the kidney. That has the advantage of not causing hypoglycemia. There is some weight loss associated with losing calories through the kidneys, but also there's a modest effect on systolic blood pressure, almost a diuretic-like effect. And again, from that class of agents, one of those medications have also been reported to show lower cardiovascular mortality and lower rates of heart failure, which is something we've never seen in the therapies for type 2 diabetes. So there's a number of agents that are available. We need to really gauge the risk of hypoglycemia, gauge adiposity and fat-related comorbidities, and the risk of cardiovascular disease. And I think those are the three main parameters to gauge. Clearly, any therapy is going to be part of a care plan, and I think it's really important to actually define the target for an individual in terms of glucose lowering. So the practitioner, the patient, and all the healthcare professionals are aware of what that target is. And it doesn't have to be a tight target. It all depends on the other comorbidities of the patient's outlook in terms of their views on therapies and their risk going forward. Well, that's a scenario we see quite often. We know that type 2 diabetes is a progressive disease, so I think we all need to appreciate, and the patients from the outset, that they will require more and more therapies, and ultimately a proportion of patients will require insulin. I think it's important to say that the number of medicines available defers the need for insulin longer. I think that's probably a good thing. However, some patients will need insulin to control blood glucose levels. What can we do before starting a patient on insulin? Well, clearly it's a good time to gauge their lifestyle, their level of ability of taking physical exercise, and their diet. Clearly, most patients will require a simple insulin regimen, one injection a day. Hopefully that they can be taught how to deliver that injection themselves. Most practices will be able to initiate insulin, but it all depends on which part of the country you're looking at. And again, those expertise will be available to a more or lesser degree at GP practices. Some GP practices refer to other practices with more specialist input. Other areas like ourselves have a community hub where we have our specialist nurses and our diabetes consultant specialists who practice there, so they may be referred to that service for advice. But clearly every practice requires specialist advice from time to time, especially for those patients on injectables, on insulin. And I think it's really up to the local health system to develop those virtual links with the community service, with the specialists, to access their expertise for each patient, especially when we're looking at injectable therapies, multiple injectable therapies and insulin therapy. The problems of insulin are well known: weight gain, hypoglycemia. There are ways to mitigate that risk in terms of patient education, but also some of the newer agents for type 2 diabetes may offset some of the weight gain we see with insulin therapies traditionally.